Just a quick overview of what to do if you have a patient that's deteriorating and an overview of the code card. Here's a quick review of the adult code card. So this is a standard code card. I just picked it up from Central Sterile today. The top drawer of a code card is always medications. So your med nurse is usually your critical care nurse or your emergency room nurse. They're the ones that really know how to administer medications. This inset can just be handed off if they'd like to do that, but all the medications are here in the top drawer. The second drawer has the things to give the medications. In addition, it has kind of some IV supplies. They are the old auto guards, so they may ask you for things off of your cart to start an IV. So IV start supplies, syringes and needles to drop some of the medications, extension tubing start kits, flushes, and tourniquets. Next is kind of your IV fluid drawer. So there is a bag of plain OR, which they may want, some smaller bags of normal saline, and then there's lidocaine, dopamine, and dobutamine that they may ask for, along with pump tubing. So your pump on behavioral health is in that back supply room at the end of the unit. Next is some sterile procedures, supplies, so gowns, sterile gloves, sterile drapes. The next drawer down is everything breathing. So don't forget that there is an oxygen tank on your code card. There is also a bag of respiratory supplies. So generally, if you have a patient and respiratory is here, you can just hand them this whole bag. And there's also the ambu bag supplies that we'll talk about here in a minute. There are flow meters, batteries, extra pads for the defibrillator, suction tubing, masks. So don't forget, if you have a patient that is still breathing, there is 100% non-rebreather that you could attach to your oxygen. So it would attach here at the back where this nipple is, and then you would turn it all the way up. So for a non-rebreather, you need to have it on 12 to 15. So you're going to twist this dial all the way as far as it can go, or at least to about the 15 mark. You see 15 to do a non-rebreather. If you have it on less than 12 to 15, they're actually rebreathing their carbon dioxide. So you're going to attach it back here, turn it up to at least the 15 mark. The final drawer is PPE. So here we have gloves. There's a central line kit that would kind of go with some of that sterile supplies in this drawer. There are stethoscopes. There's a blood pressure cuff, a manual one, a suction regulator and equipment. Usually there's a suction canister on the top. So the extra supplies for it, red bags, gowns, and eye shields. There used to be N95s in here. They are no longer. You would need to grab them from your unit supply. So some things that you can do in the event of a MERT is kind of get them set up, get oxygen on them, and we'll talk through putting defibrillator pads on here in just a minute. Here's Intera's job aid on when to call a MERT, and then here in a minute we'll talk about behavioral health specific emergencies. So reasons to call a MERT include changes in level of consciousness, changes in respiratory status, symptomatic changes in heart rate or rhythms, especially if it's not normal for the patient or they feel bad with it, symptomatic hypotension, so dizziness or whatever with the low blood pressure, hyperkalemia, chest pain or pressure, and you should always call a MERT if you do an EKG and it says STEMI. New repeated prolonged seizures, suspected sepsis, reactions to medications, acute reduction in urine output, and then any symptoms of a stroke. So we use BFAST here for stroke, so problems walking or with balance, vision problems, facial drooping, numbness, uneven smile, weakness, numbness, paralysis in arms or legs, slurred speech or issues with speech that had not been present before. And then the T for B fast is when were they last normal. So we're going to start with some psych-specific emergencies. So it's important that we keep in mind, based on our patient population, some medication issues and other things that may cause problems with our psych patients. So we're going to start with dystonic reactions. So this is abnormal muscle tone and spasms of the head, neck, and back. These should always be called to the doctor, but if they are obstructing their airway, this would definitely be a MERT situation. So your treatment starts with anticholinergics like cogentin, antihistamines, and then there's some other medications that can be used as well. Neuroleptic malignant syndrome can happen to any patient who's on a neuroleptic medication or who has gotten one, such as Haldol, Risperidone, clozapine, and others. So muscle rigidity, dystonia that we just talked about, mental dullness, and then the hallmark of neuroleptic malignant syndrome is fever. So increased temperature, increased heart rate. For these, you want to cool them down really quickly and often get fluids and electrolytes. But this is definitely a medical emergency. Patients who have been on benzos and are withdrawing from them, or alcohol, which is a benzo, can seize. That's the highest level of withdrawal issues for benzos and alcohol. So if your patient does have a seizure, making sure that you put oxygen on them, we're not putting anything in their mouth, try to keep them protected from hurting themselves, put a pillow around, but don't hold them down. Opiate withdrawals can cause electrolyte imbalances just because of all the nausea, vomiting, diarrhea, abdominal issues. You also will see sweating, maybe dilated pupils, increased heart rate. So just watch out for electrolyte imbalance issues from those. Any electrolyte imbalances can cause heart problems, so just keep those in mind. Rhabdo is something we also see occasionally, especially with people who are posturing a lot, who maybe have fallen. Pressure can cause rhabdo. So dark urine, muscle cramps, and fatigue are all part of the rhabdo. Treatment is usually fluids, again, electrolytes. This is also a good time to talk about seizures versus pseudoseizures. So a pseudoseizure is simply seizure activity, but when you do an EEG, they don't have a seizure in their brain. So a lot of psych patients, or a lot of pseudoseizures patients also have psych issues, and really the only way you can tell is by an EEG. Lithium toxicity also should be mentioned. So your normal lithium level is 0.6 to 1.2. Over 1.2 you get mild lithium toxicity, and then in moderate and severe. Severe lithium toxicity can kill you. Seizures, tachycardia, coma, and delirium. So if you have a patient with a high lithium level, we need to really be watching them and making sure they're okay. Fluids, just to dilute that lithium level, anti-seizure medications if they are seizing, and then electrolyte replacement. Your role in a MERT. So to call a MERT, you're going to use your Cisco phone and dial 12, so it's just 12 and then the call button. And that's going to bring you to the top of the list for the operators. So just like you would call a security alert potential situation, you'd call medical response team, 5 East, and then the general area. Have somebody get a code card, get a set of vital signs, get a blood sugar, apply oxygen, make sure that this is not a code, so check for breathing and a pulse. Apply defibrillator pads, and we'll look at that here in just a minute, and turn the dial to 1, which is energy. That will give you at least a rhythm. If the patient does not have a pulse, you're going to use the analyze button and follow any directions there. If you can, start an IV. And then one of the biggest things for people to do in the event of a MERT or code is letting people on the unit. So a lot of the code or MERT team does not have access to behavioral health. So you need to make sure there's somebody there going back and forth between the doors, or somebody in both doors letting people on. Writing down what happened and the vital signs. And then the primary nurse really is supposed to stay through the whole thing because you are the expert on that patient. The primary nurse must stay. Charge nurse should stay. Of course, sometimes that's your whole nursing staff.
But making sure that at least the primary nurse or the person that knows the most about that patient is with the patient for the MERT team. Even if you are the newest nurse on the unit, you still need to be there.
To use the defibrillator, you're actually going to unplug it from here. So I'm going to turn it to the red to 1. I'm going to follow my numbers. Turn it to red. I have my adult pads, and they are going to hook up here.
Check pads.
So what I'm looking for is this white clip attaches to the lightning bolt. So my white clip is attached to my lightning bolt. I have pads, and I'm going to apply the pads the way that they show on the diagram. So here and here, the pads just can't touch when they're on the patient. Alright, so I have my pads hooked up and my patient is in VFib. If I am ACLS trained, I can use my judgment and just charge and shock. If I am not ACLS trained, then I'm going to use this in AED mode. So to use this in AED mode, I'm going to use Analyze. So I'm using Analyze. CPR is ongoing.
Stand clear.
When Analyze starts, you stand clear. When it goes to this high-pitched noise, you can start CPR until you've got your red button. At this point, you clear the patient. I'm clear, you're clear, oxygen clear, and you deliver a shock while looking at the patient, not looking at your button.
Perform CPR.
So at this point, we're going to go back to CPR. It's going to count down. You'll see you've got your timer here. It's going to count down until the next rhythm check. So we're continuing CPR until it tells us again. If I am ACLS trained and I had not used Analyze, it is not going to give me this 2-minute countdown. We have to keep track of those 2 minutes ourselves. It does not give you your 2-minute countdown. So your steps are 1, electricity, Analyze. If you are not ACLS trained, charge if you are, and then shock. 1, 2, 3, and making sure that you unplug it from here.
So pad placement, here's a quick diagram on pad placement. So right upper and then left lower kind of under the armpit, and you can see the diagram of why we do that. So you're trying to get the electrical current across the heart, trying to make sure that there's not too much hair, that everything's stuck. There is in the bag with the pads a razor and a towel, so if you need to dry them off or you need to shave them real quick just to get enough hair off to get a good pad placement. You may need to work around breast tissue. Just do the best you can to kind of get that heart sandwiched in the electricity. So to use an ambi bag, you're going to need to do a couple different steps. So when you get the ambi bag out of the bag on top of the code cart, it's actually going to come in a couple different pieces. So first of all, we have this kind of football looking thing, and it's going to be compressed. You're going to actually have to pull this end and this end apart, and that's going to make it look like a football. So if it doesn't look like a football, pull until it does. Then you're going to need to take the mask and attach it. So the mask will attach to kind of this end. And then the third point is that you're going to need to take your oxygen tubing and attach it to the oxygen tank on the code cart and turn it up to that 15 liters. So step 1, grab it. Step 2, pull it apart. Step 3, put the mask on. And then step 4, go ahead and plug it into oxygen. So proper ambu bag technique, the first thing you're going to do is open the airway by pulling up on the chin. That's called a chin lift. If they have fallen, you can do a jaw thrust where you just pull up instead of tilting back. And then you're going to apply the mask by kind of stretching it out across their face. That gets you a better seal. And then holding it in this position. So if you'll see here, we call this the EC technique. So the thumb is at the bridge of the nose, and then the forefinger is holding the mask down onto the chin. And then these fingers are called an E. So instead of just like shoving the mask down, you're actually lifting the jaw to the mask. So I've got my mask kind of spread out and applied to the face. This here is across the bridge of the nose with my thumb, and then your finger goes to the chin, and then these fingers hold the jaw into the mask. If you can do that on both sides and somebody else squeezes the bag, that's great. You get a better seal that way. That also works for RQI. And if not, then one hand holds the mask and the other hand squeezes the bag. You're only going to squeeze the bag until you see chest rise. You don't want to overventilate because that just traps air into the stomach and prevents good perfusion. So the BLS algorithm looks like this. We're all really good at CPR now, except not really good at the ratios anymore, because all we're doing in RQI is 60 compressions and then 12 ventilations. So your algorithm starts with CPR. You're doing 30 compressions with 2 breaths, and then use the AED as soon as available. So what makes the biggest difference in a code situation is actually high quality CPR and early defibrillation. So once the AED arrives, you're going to check if that rhythm is shockable. If it's shockable, you're going to give a shock. And then as soon as that shock is delivered, you're going to resume CPR starting with compression. So if you were already on compression 15 and you stopped and gave a shock, you're going to start again at 1. And that starts a whole new cycle of the 2 minutes or 5 cycles of CPR. So a reminder that the AED will count down if you use it in analyze mode and an AED mode, but otherwise it will not, and you'll need to keep track of those 2 minutes. So as BLS providers, that's going to be kind of the route. If it's a MERT, somebody's just unstable, you're going to get them on the monitor, you're going to get oxygen on them, you're going to call for help, obviously first. There's certainly steps you can take if a patient does not have a pulse. Early, high-quality CPR, put them on the defibrillator and use it in AED mode. Early defibrillation, good CPR makes all the difference in the world while you're waiting on the ACLS team. Your compression rate is 100 to 120. Again, that's being really well tested with RQI. And that's it for today. I hope this helped and it gave you a better idea of how to handle emergencies.